Thank you, Emma. I hope you can all see my screen okay. So I'm going to run through highlights of the report. This isn't really a perfect summary, and I'll try and give a bit of a flavour of the status quo in New Zealand. I just want to acknowledge my co-authors on this. It certainly wasn't a solo effort. So just highlighting some of the sort of demographics of methamphetamine usage in New Zealand. It's quite a small number of people who use methamphetamine. About 1.2% of the adult population have used it in the last year, but only about 8,000 people use the drug at least monthly. And like Norway, New Zealand has a population of about 5 million, so the numbers are quite comparable. For the people who use methamphetamine regularly, they're likely to be somewhat older, in their mid-30s, male and Māori. So 38% of the people who use regularly are Māori, whereas they make up only 17% of the general population. Methamphetamine usage is much more likely in poorer neighbourhoods, and by people living with disabilities. And there's just been a research paper coming out that's looked at the determinants of or factors that make people more likely to use methamphetamine, both when they're younger. There's sort of things like family turmoil, antisocial behavior, and when they're older, it's stressful events like unemployment. In New Zealand, usage is concentrated in rural towns in Northern, Bay of Plenty and Hawke's Bay. This is the north and east, the North Island, and these are places with large Māori populations. We've also looked at the reasons that people use methamphetamine. One group that stood out and which somewhat surprised us was adults with undiagnosed ADHD, that's attention deficit and hyperactivity disorder. There are a few interesting things. Despite what we know about the demographics, our treatment and service provision doesn't line up with it very well. A lot of the treatment provision is actually in the larger cities rather than in the smaller places where there are a large number of people using methamphetamine. Despite the large number of Māori people who use methamphetamine, there's very little provision of what we call kaupapa Māori treatment, which is treatment based on a kind of a Māori cultural view or a Māori philosophy. And these programs are generally more effective for Māori people experiencing addiction. Just coming, so that's the demographics. Treatment is obviously really important. We have some really good treatment approaches in New Zealand, but we lack resourcing, so people are often waiting a long time to get them. And about half of people who want treatment miss out. And again, some of those things are inaccessible. We've also looked at how effective treatment is. This is actually from an Australian study, which is comparing people who receive no treatment with those who go through a residential rehab program. We see that even if people don't receive any form of treatment, generally over time, their methamphetamine usage will decrease, and some people will give it up entirely on their own. But if we look at those who receive treatment, the picture, if your goal is abstinence, is not very positive. 3 months after residential rehab, more than half of people have managed to be abstinent, but that drops down to only sort of about 25% after 3 years, which is actually relatively low. But if we take a broader view of what treatment does, and instead of focusing entirely on abstinence, we look at people's well-being, things that they believe are important to them, so their ability to hold down a job, maintain relationships with people, to feel calmer, to have a bit more impulse control, those kinds of outcomes, treatment starts looking much more effective. And if we look at people's ability to use methamphetamine less than weekly, then the treatment is actually really quite successful. And, the large majority of people going through treatment experience positive outcomes. It does also suggest that sort of, it's not just about one round of treatment. Sometimes some follow-up and aftercare is also needed. So I'm not expecting people to see what's on the slide. I would definitely recommend reading the report. But we did map out the harms from methamphetamine. We looked at the whole supply chain from production, wholesaling, retailing, consumption, where people get the money for their consumption, as well as the legal framework, and mapped out the harms and who those harms accrue to. We didn't attempt any quantification. But I'm just going to pull out a few highlights for you. One is that just a few sort of facts about the New Zealand market. We used to have a lot of domestic manufacture with the use of pseudoephedrine, which is an over-the-counter cold remedy, which can be made into methamphetamine. But over-the-counter sales were banned in an attempt to control methamphetamine. It didn't really have any impact on methamphetamine usage, but it does mean that most of our supply comes from international cartels, some from kind of the Golden Triangle in Southeast Asia, and quite a lot from Mexico. This has definitely changed the dynamics of the local market, arguably become more violent, partly as a result of that. And it's also enabled other drugs such as cocaine, which used to be almost unheard of in New Zealand, to become relatively popular. New Zealand has some of the highest prices in the world for methamphetamine, which means we have very large profit margins. There's a lot of very aggressive marketing of the drug. And in some areas, this has led to reduced availability of anything else, particularly cannabis. We also found that regular users often end up selling the drug to pay for their supply. New Zealand has a form of decriminalisation, but anyone caught with a small amount of the drug, it's up to the police discretion whether or not to prosecute them. And police are only supposed to prosecute if it's in the public interest. Unfortunately, that discretion is used in quite discriminatory ways. They're much more likely to prosecute people who are Māori, and they're also much more likely to prosecute if the drug found is methamphetamine versus other drugs such as cannabis. And the fact that people who use often end up also selling the drug means that decriminalisation doesn't necessarily help them, because they may well be being prosecuted for selling. We've also had some quite significant impacts from the stigma and fear of the drug. We had a huge moral panic in New Zealand about methamphetamine contamination. Obviously, methamphetamine production, labs are can be really toxic environments, but the fear was not about those. It was about any indoor environment where people had consumed methamphetamine, where they'd smoked it. And so our social housing provider ended up evicting large numbers of tenants simply for consuming methamphetamine, which made a whole lot of people unhoused because they were already with the sort of last possible housing provider. And it also led to some very expensive and completely unnecessary remediation, and cost millions and millions of dollars for no reason whatsoever. And the last thing, there's a little bit of a thread about ADHD here, which is an unmet health need that leads people into the black market to treat themselves. The drugs used to treat ADHD are themselves stimulants. But because of the kind of panics around methamphetamine, we have very strict prescribing controls on methylphenidate, which is Ritalin, and dexamphetamine, which is a type of amphetamine, much stricter than benzodiazepines, which also have quite high potential for misuse. But probably, we've went through all the health impacts from methamphetamine usage, but the punitive approach has been really bad. We've seen more than 12,000 people convicted of methamphetamine offences in the last 5 years, and almost 4,000 of those people have gone to prison, which has a huge impact on those people, their families, their communities. And none of the measures we've taken have really led to any significant decrease in methamphetamine usage. Our methamphetamine usage rates sort of seem to fluctuate a bit, but they're relatively stable. And yeah, none of our interventions seem to have worked particularly well to date. So we made a number of proposals in the report. Again, I would advise reading it to get a sense of what those are. Um, we really want to make sure that there's actual proven health-based community approaches rolled out. We have a program called Te Ara Oranga in Northland, which has been very successful. That is a model of cooperation and collaboration between the local healthcare providers, the hospitals and the GPs, as well as the police and social services, to take a decriminalisation approach to divert people out of the justice system and into healthcare system, providing wraparound social support, and also has had quite a strong sort of multicultural element to that. We would like to see it rolled out nationwide. It has a very high benefit to cost ratio. For every dollar investment program, getting $4 to $7 worth of value back, but it's only been extended to one other region at this point. We've also proposed piloting a substitution therapy style treatment. We have very successful opioid substitution therapy in New Zealand, and there are international models of substitution therapy, Switzerland most famously with their heroin-assisted treatment, and Canada has also been recently exploring models of substitution therapy and safer supply. We also think there are multiple reasons why people use methamphetamine that can be addressed and should be addressed. And one of the more obvious ones is people with untreated ADHD. We also want to see much better harm reduction for people using methamphetamine and a general sort of destigmatization so they can get help and support more easily. And we really want to see the decriminalization improved, and so that just criminal penalties don't apply for use or possession of methamphetamine, because it's really important to take away the police discretion and opportunity for discrimination. So that's all I have to share. Thank you.